Okay, hello everyone, and welcome to the webinar, How to Streamline ACEs Screening Using CHADIS, presented by the Center for Youth Wellness and Total Child Health. My name is Leena Singh, and I'm the Program Director of the National Pediatric Practice Community on ACEs at the Center for Youth Wellness. On behalf of both my team and the CHADIS team, thank you for joining us today as we officially launch this exciting collaboration. Some of you joining today may be currently using or interested in the Child Health and Development Interactive System, or CHADIS, and others may be looking to screen or are currently screening for adverse childhood experiences, or ACEs, within their medical practice. So today we hope to address questions about CHADIS, ACEs science and screening, how the ACE screening tools function within the CHADIS platform, and how this collaboration can help support your efforts and promote the widespread implementation of ACEs screening in practices across the country. This is who you'll be hearing from today. As I said, my name is Leena Singh, and I'm the Director of the National Pediatric Practice Community on ACEs at the Center for Youth Wellness, and I'll let Barbara introduce herself. Barbara?
Hi, I'm Barbara Howard. I'm the President of Total Child Health, the creator of CHADIS and distributor of CHADIS. I'm also an assistant professor of pediatrics at Johns Hopkins, and I'm proud to say that I'm a practicing pediatrician. In particular, I'm a developmental behavioral pediatrician, and so dealing with ACEs and making it possible to do that in primary care is close to my heart.
Great, thanks, Barbara. So we want to be sure that everyone can actively participate in today's webinar, so please look to the top left or in a pop-up box for the chat function within Zoom. This feature enables you to chat either with the panelists or with everyone on the webinar. During the presentation, we encourage you to dialogue with each other and ask questions via the chat function. Our team will try to respond to as many questions as possible during the webinar, but any we don't get to now will be addressed in follow-up communications. So I'd like to begin by talking a bit about the science of adverse childhood experiences and toxic stress. Adverse childhood experiences, or ACEs, are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or the ACE study, which was conducted in 1998 by Drs. Felitti and Anda. The study was a partnership between Kaiser Permanente and the CDC, and it was one of the largest investigations ever conducted to assess connections between early adversity and adult health. The study had over 17,000 participants who were primarily Caucasian and college educated. So this study is the basis for the core 10 ACEs that are often characterized into three categories that you see here: abuse, neglect, and household instability. So these ACEs include physical, emotional, and sexual abuse, physical and emotional neglect, living in a household where a member has a severe mental illness or substance dependence, where the child has witnessed some sort of violence against their mother, or there has been separation from a caregiver due to incarceration or divorce. And researchers continue to build understanding around these core ACEs and other potentially traumatic experiences in childhood that are associated with negative health outcomes. So what the ACE study told us is that ACEs are incredibly common among the population, with over 2/3 of the adult population having experienced at least one ACE. We also have data that shows that nearly half of all children today have experienced at least one ACE. The study also pointed to a dose-response relationship, meaning that the more ACEs that someone had, the greater their likelihood of negative health outcomes. So as you can see in this slide, we show the leading causes of death in the United States, and you can see the drastic increases in likelihood with 4 or more ACEs. Similarly, we find that health and developmental concerns associated with ACEs also appear during childhood. So among infants, studies have found associations between ACEs and growth delay, cognitive delay, sleep disruption. In middle childhood, we find associations between ACEs and asthma, reoccurring infection, learning difficulties, behavioral problems. And then in adolescence, we find associations between ACEs and violence, bullying, smoking, teen pregnancy and teen paternity, and weight management. So the question is, how do these early social experiences turn into health-damaging ones? What we now understand is that these early experiences act as a stressor on the body, and in doing so, activate our stress response. And while this stress response is highly adaptive and generally functions well, when it's activated over and over again, it becomes health-damaging. This arrow here shows us the spectrum of the stress response, including positive, tolerable, and toxic stress. And the physiologic response to stress depends on the nature of the stressors and the availability of buffering and coping strategies. So a positive or tolerable stress response is characterized by a return to homeostasis, whereas a toxic stress response may induce more lasting changes. Toxic stress is characterized by prolonged or frequent activation of the stress response that leads to a dysregulation of the neuroendocrine immune circuitry, and this produces altered levels of important hormones and neurotransmitters, and can ultimately lead to changes in brain architecture and multiple organ systems. But ACEs aren't the full story when it comes to determining a child's risk for developing toxic stress. So this scale is borrowed from the Alberta Family Wellness Initiative, and it provides a good way to explain why this is. So think of the scale as weighing the things, both good and bad, that may affect a person's health. The positive things are called protective factors, things like an attentive caregiver, other things that help create a safe and stable foundation to promote health. And then at the other end of the scale holds the bad things, the risk factors. ACEs are risk factors. And then there's the fulcrum. So the fulcrum represents the biological makeup of a person. Our biological makeup includes our genes, which may make us more or less susceptible to stressful experiences. And although our genes don't change, other factors may influence how our bodies react to stress. So one reason we focus on children when we talk about ACEs and toxic stress is that children's brains are particularly malleable and therefore impacted by both positive and negative experiences. On the scale here, we see that the position of the fulcrum affects how much leverage protective and risk factors have in shaping our life outcomes. So a person with a scale that's weighted down by risk factors will have increased risk for stress-related diseases. I also want to note here that there are many potential pathways through which a person's health may be influenced by their social experiences. So we're focused on ACEs as a risk factor for toxic stress. The broader term social determinants of health often refers to structural factors that influence health. For example, access to healthcare services, transportation, income, education. We know that these factors may also impact patients' health outcomes, but they may do so through pathways other than toxic stress, like making it difficult for a patient to get medications or to travel to the clinic. This distinction may matter when we think about why we're screening for ACEs and what it means in terms of prevention and follow-up. So let's look a little closer at how toxic stress may impact the body. So this image outlines the multisystemic effects of toxic stress. The neurologic effects can include overactivity and difficulty turning off the stress response, increased fear response, impaired executive function, difficulty with learning and memory, and increased risky behaviors. The immunologic effects can include changes in inflammatory mediators and markers of inflammation, which can lead to increases in infections and chronic inflammation. The endocrine effects result in long-term changes to hormones involved in stress activation, changes in hormones related to growth and puberty and metabolism. And research has also found epigenetic effects, which includes changes in the way that DNA is read and transcribed. which can lead to changes in the way that the brain and the organ systems respond to stress, leading to premature cell death, altered cell replication, which increases the risk for chronic diseases such as diabetes and cancer. And as we see, there can be substantial individual variability in how early adversity and toxic stress manifests over the life course. So in this image, we see a few different possible trajectories as examples. If we start here at the top, it's possible that an individual who experiences ACEs doesn't present any symptoms and ends up having a healthy life. Moving to the very bottom, we see an individual who experiences toxic stress, shown as disruption to the neuroendocrine and immune functions, which manifests as social, emotional, and cognitive impairment, leading then to the adoption of health risk behaviors, and then leading to disease and disability. These are likely individuals that you already identified through your practices as needing some sort of extra support or intervention. But in the middle here, we see a child who has experienced toxic stress, but perhaps doesn't present the more obvious behavioral symptoms. Perhaps their symptoms are in the form of failure to thrive or ADHD, reoccurring infection, uncontrolled asthma. Perhaps this child has no recognizable symptoms, but as an adult still experiences premature disability or disease. So the varied presentations of toxic stress physiology make screening for the risk of toxic stress essential, even for those who may not be obviously symptomatic. So the good news is that we can do something to prevent toxic stress. And we can do this by reducing exposure and promptly intervening. We reduce exposure by systematically screening all kids for ACEs, early identification and intervention, which is something that Barbara is going to be talking about in a bit in terms of how the CHADIS platform can help support this screening. We couple this screening, this early intervention, with prompt intervention. We couple the screening with prompt intervention, and this intervention falls into 3 different categories. The first category is about enhancing protective factors, including strengthening parenting skills, helping families reduce their stress, focusing on good sleep hygiene, nutrition, exercise, and mindfulness or meditative practices. The second category of intervention is about addressing other modifiable risk factors, such as transportation or housing barriers, that may increase insecurity and stress for families and can also create barriers to healthcare. And the third category is about linking children and families to therapeutic intervention, in particular, those who have been exposed to high doses of adversity. And with young children, this often means dyadic therapy for the caregiver and the child. So now that we've talked a bit about the science of ACEs and toxic stress, I'd like to share more about the Center for Youth Wellness and the National Pediatric Practice Community on ACEs, or the NPPC for short. So the Center for Youth Wellness is a pediatric-focused organization based in San Francisco, and we were founded in 2012 by a pediatrician, Dr. Nadine Burke-Harris. CYW, the Center for Youth Wellness, focuses on the issues of ACEs and toxic stress in pediatric medicine. We screen every child for ACEs in partnership with the Bayview Child Health Center, which is a pediatric medical clinic, and children with high ACE scores are then referred to CYW for intervention, including psychotherapy, counseling, biofeedback, care coordination, and a range of other services. So we work in 3 distinct areas. Our direct service work serves to advance clinical practice related to ACEs. Our research arm aims to translate and build the scientific foundation of the field. We're currently in the process of validating an ACEs screening tool. And we want to raise awareness and build a national movement around ACEs. Our vision as an organization is that all primary care medical providers implement universal screening for ACEs and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So while CYW has developed our own integrated model for ACEs screening and intervention, we recognize that there are many providers around the country who are interested in this issue and are currently screening for ACEs, and that there's still a lot to learn about emerging science, and implementation needs across healthcare delivery settings and communities. So we are convening these providers into a national network through the National Pediatric Practice Community on Adverse Childhood Experiences, or the NPPC. So the NPPC is a co-designed learning community of pediatric medical providers who are really leaders in advancing clinical practice around ACEs in primary care and focused on integrating ACEs screening and intervention into practice. Our goal with this network is to advance the dialogue, raise questions, push the fields of research and medicine forward, allow research to emerge from practice, and to provide a network of resources and support around the science of ACEs, the implementation of screening, and the development of integrated referral systems. We have a virtual network of providers that is currently 550 plus members strong, and all members have access to our member website, which offers tools and resources for practice. We have patient education resources, contextual supports that are needed to support screening from an organizational perspective, and the latest scientific information on emerging research related to ACEs and toxic stress. So our goal with the online community is to virtually support medical practices and providers to implement screening. Doing something new is not always easy, and we recognize that. Some of you who have implemented or are trying to implement ACEs screening in your practice may have experienced some of these feelings that you see here: hopelessness, frustration, anger, confusion, maybe all of them at once. So we hope that in addition to convening a practice community on this topic through the NPPC, making the ACE screening tools available in a platform like CHADIS can help streamline the process and facilitate the widespread adoption of screening. And of course, we welcome all pediatric providers and their care teams to join the NPPC on ACEs and gain access to this community and our resource offerings. You can go to nppcaces.org, read more about this initiative, and click join to enroll. When you join, we ask you to fill out a short questionnaire and accept the member agreement. I want to note that there's no required contribution to join, but we do hope that all who join actively engage with this network. The NPPC team is available for questions or consultations, and if you'd like additional information, please feel free to contact me, Leena Singh, and you can see my email address here. And now I'm going to turn it over to Barbara to talk more about CHADIS.
Great. Well, thank you so much, Leena. That was an excellent presentation on the basic science of ACEs, which comes across as a complicated process, and you've made it very clear. So thank you very much for that. And if you could help me advance the slides, I think hand over the ball to me. That'd be perfect. Great. So I just want to point out that that not only your patients are stressed by ACEs, but we're all under stress as healthcare providers as well. Now, it's really not comparable to what our patients are dealing with, but it's significant, and it's something that needs to be addressed also. So we know that patients want their concerns addressed, they want to share in decision-making, and they want evidence-based comprehensive care. And of course, as clinicians, we all want to do that too. But here we are in the middle of this picture, drowning in a sea of recommendations and requirements, often with a lack of training for the kinds of work that we're trying to do, particularly the work related to psychosocial care of entire families. And of course, we also have a need to get our Part 4 maintenance and certification credits. So I have good news for you, because we can help you with all of those things. As organizations, we have also got regulatory and certification standards that need to be met while making the practice efficient and have a good reputation for quality, and also dealing with payment, including new alternative payment options. So CHADIS is really a solution that we came up with a number of years ago, which is intended to help the clinical process in all of its aspects. So we call it a clinical process support system. So there, before the visit, you can see that patients do questionnaires online before the visit, either from home or in the waiting room. And we have a nice collection of over 400 tools from which the clinician can choose which tools to assign automatically, as I'll explain in a minute. And then during the visit, you as a clinician get moment of care decision support. And that's really helpful because you really care about that support right when you're facing a problem, maybe one that's difficult or you haven't faced before. The kind of decision support we offer includes scored results, even automatically adjusting for prematurity, graphic displays of some kinds of things, and I'll show you a few examples, patient-specific templates, and one of these is for family stress, and care coordination functionality that makes it easier for you to refer a patient outside of your medical center and still get feedback and convey an electronic online consent form. So after the visit, each patient gets their own individual MemoryBook care portal for their child, pre-populated with milestones, as I'll show you, but also a place where patient-specific education and resources, including local resources, show up. Now, CHADIS also allows you to schedule screening tools to remind the patient automatically at intervals to do tools to help track outcomes, and has a database of over 20,000 local and national resources. And when you sign up for CHADIS, we'll add your favorites locally. And then for clinicians, there's education in the form of e-chapters, some videos, in particular some great videos made by Howard Dubowitz at University of Maryland about how to talk to families about these social determinants of health, as well as the ability to get Part 4 maintenance and certification credit. So that's the overview of the system. This is more of a schematic of how it works. So there's the parent up there in the top right-hand corner doing their questionnaires from home. A teenager can log in and do questionnaires under their own separate login. Neither one sees the other person's results. And in fact, they can see the answers they submitted, but they don't see any scored results because we don't think it's fair for a patient to try to interpret a screening tool based on numbers all on their own. And that would apply, for example, to an autism screen, which is one of the tools offered by CHADIS. We don't want parents to find a positive screen for autism at home in the middle of the night. So this is designed for clinicians to use as a point of discussion with families to further determine whether screening tools are accurate and what this particular family's problems are or strengths are right now. And as you can see, the clinician can communicate electronically and securely with people in the community like teachers, over there to the right, or therapists down there to the bottom right. And then materials go to that MemoryBook care portal, some of them automatically and others because the clinician chose. At the bottom, you see that MOC4 certificate. On the left, it's nice to see that, in fact, screening tools are now authorized to be billed to the child's insurance. And so that means that people can actually help defray the cost of spending time on these issues and actually earn extra money by screening whether the screens are positive or negative. So let me explain it just a little bit more to make it clear. Once an office chooses to sign up with CHADIS, they sign a licensing agreement, and then with the help of our staff, they get to choose which kinds of appointments patients would recognize, and then they set up the questionnaires they want to be administered to patients who are coming for that kind of visit, depending on their age. The patients only need one simple invitation code, usually the office phone number, to register themselves and their child and to see the questionnaires they're supposed to do and to complete them. Now, this is really an important efficiency of CHADIS because you know that the person at the front desk is the most critical member of the healthcare team in many ways, because it's all on them to identify the patients properly, sign them in, and then make sure that they've either done questionnaires in advance or hand them that clipboard, which is what's often done around the country. So this makes it much easier. People can be invited to use the code by email or by registering your whole panel of patients. And certainly at the time that they make an appointment, they would be reminded to do questionnaires. There's actually automatic reminders for questionnaires associated with well-child visits as well. Teachers and other caregivers can also register in CHADIS and provide feedback. This is particularly important because either the parent or the office staff can send an invitation to the teachers to collect information, for example, the Vanderbilts for ADHD care. And this slide doesn't capture the 400 questionnaires. You'd never be able to read them on one slide. But what it does show you is something that we learned early on about CHADIS, and that is that doctors don't want to use a different system to screen parents for their depression, kids for their development in autism, teenagers for depression, and for other kinds of social risk factors like the ACEs. So what we've done is we've put everything you need, absolutely everything, into one system so that they can be automatically assigned. And of course, you can always choose to use them individually as well. So you see that we have screening tools for infants and young kids, school-age kids, including the ACE-Q, which I'm going to describe to you in a minute. That's the one that the parent does about the child. The adolescent tools include the ACE-Q for teen self-administration. There are some tools for teachers, and we have everything you need under Bright Futures. Obesity, nutrition, safety guidance topics, everything that you need, EPSDT questionnaires, a very strong asthma toolkit for you, as well as family and environment tools, which include not just the ACE-Q, which is about the child, but also the ACE and positive childhood experiences about the adult, which I'm going to explain a bit more. You can see that we also have separate individual tools for things like partner violence. We have the very excellent tool called the SEEK, which is a safe environment for every kid, that I'm going to discuss a bit more, and that's been shown to help reduce child maltreatment. And our modification of that tool, which is called the Family Assessment of Safety and Stress. You can even turn on and turn off a quality monitoring tool, which is anonymous, and you can have tools that you want made into tools in CHADIS by request. So patients can do questionnaires in CHADIS on any kind of device, but you're probably thinking, if you're thinking here at this seminar, you're thinking about adverse childhood experiences, you may be dealing with a particularly stressed population, and you're wondering, will they be able to do questionnaires on a computer? So we did a study a few years ago in Baltimore, and we have our share of stressed and low-income and parents who are participating in research and also being cared for in our clinics. And we compared doing questionnaires on a computer, that's like a laptop, by phone, where they hear the questions and push buttons for the answers, compared to a tablet, and all of these were compared to paper. Now, this was done a few years ago before everybody had a smartphone, but CHADIS also works on a smartphone. And so what we found was that the low and middle income families all preferred to do questionnaires from home if they had the chance. But if they didn't have the chance, they all preferred a tablet over other modalities. And the lowest income families actually had least preference. The least preferred was paper. So that's really useful. I think it may be because of their own embarrassment over literacy skills, and the computer actually helps them with that. Now, can I go back here? Yes, sorry, skipped a slide. So once the patient logs into CHADIS, they immediately see, they register, and they immediately see a set of questionnaires. They can preview the tools, or they can just press begin, and then they immediately see tools to fill out. All they have to do is click off the radio buttons to be able to do those. And CHADIS can also be done in what we call kiosk mode, which is one question at a time. And they can touch those buttons, the yes and no buttons, with their finger. So that makes it easier for people who are not quite as facile with computers. Now, I want you to notice up at the top right-hand corner there that the patient themselves can change the language of the tool. So everything in CHADIS is in English, Spanish, and French, and we have a little bit of Chinese as well. Now, if you have a particular patient population and you can help us with translations, we're happy to make translations of these tools into other languages. And the good news is that it appears in Spanish for the patient, like as shown here, but the answers come back to the doctor in English. That's important because while the patient may be more comfortable understanding questions in their native language, the doctors may not. And so it's very difficult for doctors to look at the results of a questionnaire where they actually can't see what it would read in English. So we've solved that problem for you. And then the clinician logs into CHADIS and sees right here, first, their top concerns for the visit today. So their visit priorities. You may have read something that came out in the press this week, actually, showing that the typical doctor spends only 11 seconds finding out what the patient's concerns are for the visit. Now, a lot of people get rattled by that, and so having a chance to fill out a questionnaire telling what the main things are you want to talk about before the visit is really important. And then you see our 2-question questionnaire results, which are the best and hardest parts of parenting. We think that that's really valuable, particularly when we're dealing with ACEs, because the hardest part may not actually be a health concern at all. It may actually be a financial worry or problem with your partner. And our questionnaire has collected those response options and also leaves room for free text responses. And then below that, you can see the other questionnaire results with the asterisks on the left showing the severity of the answers in this particular case. So there you see the MCHAT with 3 stars. That's because the child failed the MCHAT in this case. So it's easy at a moment's glance to see which things you should be paying most attention to during the visit, both the parent's chief concerns and the questionnaire results, so things don't get missed. And in every case, the clinician can click a link and see the actual questions that were asked and answers that were given that they may want to review with the family. So now let me talk about how the ACE tools from the Center for Youth Wellness are fitting into CHADIS, and we're very excited to be able to provide these tools to you. So first I'm going to tell you about the ACEs experienced by the child, and these are the questionnaires called ACE-Q from the Center for Youth Wellness. It consists of first 10 standard ACE items, the ones that Leena told you about earlier, but then they've added 7 additional what you might call environmental stresses, which are things that are not captured in those initial 10 items. Now there's several forms of the ACE-Q. There's the parent reporting about their child, there's a parent reporting about their teenager, and then there's a teen self-report. And we've created 2 different views of the results in CHADIS. One that shows the actual stressors that were endorsed, and one that simply gives you a score, a total score. So here's an example of those standard items, and as you can see, the instruction is how many apply to your child at any point since your child was born. And they just click off those yeses or nos over there on the right. So these are the 10 standard items. And then this one is, at any point since the child was born, have they experienced these 7 additional items? Now, these are really important, as you'll recognize here, looking in them over. If the child was in foster care, if the child was harassed or bullied at school, which can be a very significant risk factor for, especially for mental health problems, and you even know that it's associated with suicide in older children. Was there a loss by death of a parent or guardian? Was the child separated through deportation or immigration? A really important and stressful and common problem right now in this country. Has your child had serious medical procedures or life-threatening illnesses? That's another stress that we know, even in families that are functioning extremely well, that can be a big predictor of later mental health problems in the child. Has your child often seen or heard violence in the neighborhood or in his or her school? And has your child often been treated badly for reasons of prejudice, race, sexual orientation, place of birth, disability, or religion? So I think those 7 items are a great addition to the standard 10 items. So here is one of the kinds of scoring results you can see, and that is where you don't get to see the items that were endorsed, but you do get to see the total score out of those 17 items. So in this case, the score was 5, which is a risk score on an ACE questionnaire. Here's another way of seeing the results, and there you still see the score of 5 failed items, but in this case, you actually see the items that were endorsed as being failed. So I'm excited to offer these questionnaires for you to use as part of CHADIS, and I know that we're going to be able to gain some important insights about this tool through the use that's possible through the CHADIS network. So now I want to tell you about some other questionnaires that are relevant to ACEs that we offer inside of CHADIS. And these are the standard ACEs of what the parents experienced before they turned 18, because these are the things that are not only affecting their long-term health and mental health, but also affecting the way they parent the child. And often, the things that happened to them when they were young may still be continuing to be burdensome to them, or it may predispose them to find partners who resemble those family risk factors they had when they were young. So this is the same 10 that you saw described before, but these are framed out for the first 10 years of the parent's life. Now, we didn't think it was quite fair to ask people about ACEs that they experienced a long time ago. I mean, the parent may be 40 years old by now, but without considering what positive things they may have experienced also. And there are a couple of reasons for that. One is, as Leena already explained, that positive experiences actually buffer negative experiences and reduce their impact. But the other thing is that in designing this tool, we included not just standard resilience questionnaire items and some from other studies that predict outcomes through parenting, in affecting parenting, but the other thing we added was things like, was there a grown-up who would sing songs to you when you were growing up? Were there grown-ups who would read stories to you? Because these are actionable items that the parent may choose to do with their child. And that's part of the encouragement of buffering parenting that we're doing, not just through the CHADIS system, but in the family stress study that I'm going to tell you about before I'm finished here. So those were some of the tools that are available in CHADIS. And now I want to show you what happens with them. So part of what we'd like to do is to help the parents chart a positive parenting experience for their child. So the American Academy of Pediatrics recommends universal use of the ACE questionnaire with parents, but they actually don't tell you what to do about it. So I know that NPPC is working on that. Well, we're working on that too. So by combining the ACE questionnaire and the Positive Childhood Experiences questionnaire, the doctor can have a conversation, or the clinician can have a conversation with the parent to say, are any of these active problems for you now? Do you need help with them now? But also to remember them as the child is growing up, to help them avoid those problems for their child. And we actually provide a little brief teleprompter of suggested language to use in talking to parents about these issues and helping them decide what they'd like to create for their child. We think a good time to do this is when the baby is very, very small, 2 to 4 weeks of age is a good time to do it, because by then, hopefully nothing bad has happened to the baby yet. So you have an opportunity to have this long-term conversation get started. And we've even created a graphic, which you could use if you want to. Basically, what you see is this graphic has been pre-populated by the results of both of those questionnaires. So on the left were bad things that happened to this parent when they were growing up. And on the right are good things that happened to this parent as they were growing up. And as you can see, the road for this child, the choice for this child could go in either direction. So we actually did some focus groups, numerous focus groups actually, with our colleagues at Kent State. And what we found was that this graphic was very interesting to families who were rating some simulation visits where we showed this to some of them and not to others. They felt as though it really helped them understand the connection between things that happened to the parent in the past and what might happen in their parenting experience, in their parenting journey. So that's why we've included this one, and it's something that's optional for you to use. Now, I told you about the safe environment for every kid and the fact that we've adapted that to something called the family assessment of safety and stress. And the reason that we adopted this tool and put it into CHADIS is because there were 2 positive randomized trials in primary care pediatrics in Maryland by Dr. Dubowitz and his colleagues that showed a reduction in child maltreatment as a result of screening with this tool and referring to a social worker who was affiliated with the practice. Now, that sounds great, but you're probably thinking to yourself, I don't have a social worker affiliated to my practice. Well, good if you do, but if you don't, that's not a reason to give up. So we're trying to make it possible to help support everybody, whether they have that kind of support available in their practice or not, to be able to address these issues. Now, the things that are covered in the FAS and the SEEK include food insecurity, parental depression, parental substance use, life stress, harsh punishment, and intimate partner violence. And it turns out that these factors are the ones that are most predictive of child maltreatment. And that's why this tool was created, because Dr. Dubowitz's one of his main clinical and research interests is reducing child maltreatment. The reason the FAS is different than the SEEK, there are 2 reasons. One is we've upgraded these questions to fit with the current standards for this area. So the food insecurity questions, for example, are the same as the hunger vital signs tools. Our substance use questions are the same as the currently recommended substance use questions from the NIH. So we've adjusted the questions in that way. The other thing is, you can see it's called the FAST Plus, and that's because something very special happens in the FAST. And that is, when an item is positive, the parent is asked some further questions that begin a motivational interview that is then continued by the clinician. So I'm going to show you how that works. It happens through some functionality in CHADIS called the patient-specific template. So you're probably familiar with templates that are part of electronic health records. Basically, that means an outline of things you should cover when you're considering a problem like this. But we've gone way past that because we've pre-populated this template with the answers from the questionnaires. So you can see in a moment whether this is an area that's a problem for the family or not. We link it to graphics for shared decision making. I'm going to show you some additional ones like that. And we produce a teleprompter of the rest of the suggested motivational interview needed to motivate action. Because you probably know this for yourself. If you just hand a telephone number for a substance abuse program to a parent who's a substance user, it's not very likely that they're going to go. But there's plenty of data to show that a specific interviewing technique called motivational interviewing increases the likelihood that you will be able to help that person get to the kind of care they need. So that's why we've built it in, because we suspect that most of you are not trained in motivational interviewing. So we're making it easier with point of care motivational interviewing suggestions. Now, we also help with documentation, because this template, this patient-specific template, creates a typed report for you that you can copy-paste into your electronic record. And it actually, CHADIS is also integrated with a variety of electronic records as well. It automatically sends educational materials to that care portal that I mentioned, and the clinician can add others if they want to. And it even allows parents to do an online consent, allowing them to share information with community agencies, and even gives the community agency permission to contact the parent directly, which is something that basically never happens. So then your patient comes back 6 months later for their next checkup, and you ask them if they ever did what you said, and they never did. And you didn't know that they didn't because you had made the referral, but they never showed up. So we're trying to deal with that very common clinical scenario. So now I'm going to show you a few of the screenshots of how it works. So here is a parent doing the FAST in CHADIS, and it says here, in the last year, have you been afraid of your partner? And they said yes. So then it asks some other questions, not this one next. First it says, are you getting help? And if they say yes, then it asks, are you getting enough help? If they say no, then it asks if they want help. And if they say no, then it asks this question: what is the main thing that makes it hard to get help or want help with this problem with your partner? And they can select different possible barriers, and that is going to be the foundation of the interview that follows. So here we are now. The clinician is now logged in, and at the top of the screen here, you can see the outline of a motivational interview, which includes reflecting on reasons not to change, empathizing, reflecting on reasons to change, and assessing readiness for change. But in this case, it's actually pre-populated by the exact things that the parent said. So I see that you're worried about your partner getting mad. And you're right that doing something about this problem has risks. It sounds like while you're in a difficult situation, doing nothing has significant risks too. This is important because issues like these are known to be unpredictable and potentially dangerous. And it looks like it's already affecting your sleep and your friends. How did I know that? Because those questions were answered by the parent as impacts of this problem. So this is the kind of prompt there is. You don't have to read it. Probably we think people will read it a few different times, and then they get more facile with the whole idea of a motivational interview. Now, I promised you some graphics as well to help with this problem. And this is a graphic similar to ones that psychologists use for motivational interviews. And what you see is there's a list of reasons not to act and reasons to act, only in this case, the reasons have already been filled in by the questionnaire by the parent. Now, in addition to that, this patient-specific template automatically creates handouts, including local resources. And these handouts are specific to the problem that they're facing and go to that care portal. So let me explain a little bit more about the MemoryBook care portal. So this looks like a baby book, right? That's why we call it a memory book, although it's not just for babies. The reason we got funded to do this was because of those pink flags at the top. And that is, these are items from a safety questionnaire that the parent also did. And these are safety items that the parent is not yet doing. By clicking on it, they'll get further instructions on what to do, whether the doctor or clinician remembers to talk to them about it or not. Now, we make it more attractive by making it a baby book and pre-populating it with the child's milestones. So there's a milestone from the ages and stages right down there, baby first time grabbing at clothes, and a link to suggestions for developmentally stimulating activities. That's actually part of our family stress study too, because those activities are parent-child activities to do. So there's a whole curriculum to help promote development and at the same time promote the parent-child relationship. Now, up at the top in the red box, you can see I've highlighted the fact that there are additional tabs in the care portal, and in those tabs, that's where the information shows up. So there we go. So here are care portal visit notes. Now that first note you may recognize was the handout that you saw being created. And when they click on it, they'll see the whole paragraph, including the phone numbers and everything else. Some of the handouts are very specific to the family. So in this case, the parent endorsed depression. And here's a handout talking about the very symptom that they endorsed in the questionnaire. So these are patient-specific handouts. Now, we have a variety of other things in the resource database. Here, for example, is a national parent support program called Parents Anonymous. When they click on it, they can see the address and phone number and website. Everything can be printed out as a handout in English or Spanish, as well as being available online. And the care coordination functionality is built right in with those features I talked about before: an online consent, permission for the agency to contact the patient, and a place for the clinician to share notes back and forth with the agency. This has been allowed by consent, and the whole process is encrypted and HIPAA compliant. So it's a new way of doing care coordination. So let me just tell you a little bit about the Family Stress Project, and I hope some of you will be interested in joining. In order to join, to find out if you're eligible, you can contact me. My email's at the bottom there, bhoward@chadis.com. So our goal is to detect family stressors and address them in primary care, to promote positive parenting, to buffer these stresses, and the ultimate goal is to reduce child maltreatment. So the intervention group will use that patient-specific template and those screens that I just discussed, screening with the ACE PCE, that's the ACE and Positive Childhood Experiences, and that FAST Plus with a group of 1 to 4 month olds, and then follow them forward with repeated times when the FAST will be administered, as well as collecting that data from a comparison sample of toddlers, which will be necessary for the difference in differences analysis at the end. The clinicians will use the motivational interviewing help to encourage the patients getting the care they need and referrals, as well as giving them ways of talking sympathetically to the parents about these problems and promoting positive development. Now, what does the office get out of it? Well, we hope that you'll think that what you get out of it is enhanced care, because these are enhanced care tools, but you can also get free Part 4 maintenance and certification credits. If you're in the intervention group, you'll do them for the Family Stress Project, but we have 4 other projects in CHADIS that the control group will get to do, and they'll also get those credits for free. You'll get to use the care coordination software. We'll provide free tablets for your waiting room for patients who might not have done things from home. Your patients will get that care portal with the patient-specific handouts and resources. By the way, I didn't mention the patients can search around in the resources on their own at home as well. And added income from use of multiple screens. So that income is there for you. We hope you'll use it, because we hope you'll do screening in this way. And it also produces some of the data you need for patient-centered medical home. So that's the project. Please contact me, bhoward@chadis.com, if you're interested in joining the project. And now we have a chance to have some questions and answers. Leena, have some questions come in?
Yes, they have.
And we're also going to be posting the webinar on our CHADIS website, and I believe it's going to be on your website as well. Is that right?
Yes, it will also be available on the NPPC member website in our media library. So look out for that soon. There's a question here around how many pediatric practices have started or are already utilizing the ACE screening tools consistently in their day-to-day care. So we can share, out of our 550 plus NPPC members, about 10% of our members are screening. But there was a survey done in 2013, and nationally, it said that about 4% of providers were screening in some form, asking ACE questions in their practice.
So that means that people are out there dipping their toe in the water, and we want more. We want more, and we want to make it easy for you as well. So be brave and do this. What you'll find is it's not only going to help with these problems, but it'll help you understand a lot of the chronic health problems that you're seeing in your patients, and you don't quite understand why.
Absolutely. There's a question here, Barbara. When is PCC going to integrate?
Well, that's a very good question. PCC stands for the Physicians Computer Company. So that's a pediatrics only a electronic health record, an excellent one, I might say. And we were just talking to them today about our plans for integration. So it'll be coming soon.
Great. And we have a nursing student joining us, and she asks, for patients that don't have access to computers or tablets, how can they have access to these documents at home?
So that's a very good question. Of course, questionnaires can be done on paper, but if they're able to do questionnaires in the waiting room, for example, as I pointed out, all the documents can also be printed. The resources can be printed, the handouts are printable, all of that is printable in English and Spanish.
Great. There's another question here. How do people feel about being asked these questions? Well, I have to say, what the research tells us is that patients and families say that they feel more cared for when their provider asks these questions. I think there's this fear of providers feeling like they're prying, or that these aren't questions that are traditionally asked within a medical setting. But all of the research tells us that it can actually help build rapport between the provider and the patient, and may actually facilitate disclosure of an adversity, if not at that visit, then perhaps at subsequent visits. I don't know if you have any other thoughts on that, Barbara.
Well, I would just add to that 10 years ago, people might have been offended by these questions. But Nadine Burke-Harris, the person with whom Leena works, has been doing a fantastic job. She's been on 2020 and TED Talks and everything else. And I think that right now the public is much more aware that these are a very important problem. And, just because a person is looking pretty well put together and middle class doesn't mean that they didn't have those problems when they were growing up. And so I think that what we're finding is the parents are grateful for your asking. And this is particularly true for intimate partner violence. I've never had anybody feel offended by being asked about that. More, they say, I'm glad you're looking out for me also.
Yeah, I agree, Barbara. That's all really great points. We have another question. Did you say that the questionnaires are also available in other languages?
Yes, so everything in CHADIS is available in English, Spanish, and French. But as I said, we would be happy to program in another language to make it available through CHADIS if you can help us with that. We don't have the ability to program every language ourselves, but if you're working in a particular language population, please just let us know which questionnaires you'd like to have in those languages, and we'll help you out. I see that Dr. Leffler, who's actually a current CHADIS user, is asking about saying that this is going to be a change in workflow, and there can always be a problem with lack of resources. Well, you're exactly right about that dealing with these things does change workflow, but the good news about it is when you're using CHADIS, a lot of the things you'd otherwise be spending your time doing, like those EPSDT questions, or going over and scoring the ages and stages, those things are taken off their plate, so you actually have more time to deal with problems that might come up. And of course, we can't fix the resources everywhere, but we're trying to help equip you with knowing what kinds of things you can do to help with these problems. And if you're part of the Family Stress Project, we'll help identify resources that may be present in your community that you didn't already know about. I see a question here from Dr. Grady asking whether CHADIS includes or is planning to include strength-based tools for neurodiversity. And I'm actually really happy to say that we have not only information about family history of things, but we have a number of strengths-based tools, including the best parts of parenting, that's one of them, but also abilities and interests for older kids, and the strengths and difficulties questionnaire, which is applicable to all ages. She has noticed in her practice a connection between ACEs and learning and attention differences, just as Leena outlined as one of the possibilities, especially in low-income kids and children of color who have a lot of extra stresses often present. And when you identify learning and attention differences, asking about ACEs is very relevant because those stresses can be making it much harder for the child to learn. Somebody asked if there's a cost for CHADIS. Well, yes, there is a cost. It's quite modest. And let me just mention that, that CHADIS actually ends up making money for a practice as much as $30,000 a year more per full-time provider because of the increased screening tools used that are billable to insurance. So there is definitely a positive return on investment for you, not just in providing better care, but actually financially from using CHADIS. I see that Andrew here noted that having a centralized place for screening questionnaires and other resources sounds like a great idea. How do you get your health organization to adopt CHADIS? Well, I love that question, of course. Get in touch with me, bhoward@chadis.com. We'll connect you up with people who are on our staff to provide a webinar demonstration of CHADIS to your group to help them understand the benefits, not just for ACEs, but for all of healthcare. Let's see, could CHADIS be used in other settings, such as a local health department or other social service organizations that would benefit from having knowledge of childhood trauma? Absolutely. Actually, we've just signed an agreement with Louisiana for implementing CHADIS in childcare, in their network of childcare centers. And I think that's a wonderful thing to do. But we have tools appropriate for mental health, actually over 200 tools specifically for mental health available. So this is great for integrated behavioral health settings and for just straight up social service or psychological services settings. So please just get in touch with me about that, and we can make sure that we show you how it would work in that kind of setting. In special settings like health departments or for home visitors, we can adjust the way the pricing is designed because only clinicians who are able to bill for their services do have to pay a licensing fee. The other people in the organization, for example, home visitors, there would not be a licensing fee for home visitors who don't get to charge for their services. So we're very flexible about all of those things. One more question here about wanting to be a more trauma-informed clinic in the health department, to hear more about using it for in obstetrics, prenatal program, and even potentially in a WIC program. Absolutely could work in all of those settings. Just get in touch with me and we'll show you around. And finally, we've got a couple of questions from Andrew about, does CHADIS collect data from its users? And he was thinking specifically about research data. So we can help you with research projects, either with the questionnaires we currently have in CHADIS, and we've got a great collection, as you can see, but also we can custom program questionnaires for your research project and provide you a data dump of your own data. We do only use data when we have permission to do that, and we only use it in de-identified form to help develop the knowledge in this field. But you have access to all of your data. So there is no there is no lack of HIPAA compliance in our organization. And you may know that when you have a computer company, you have an obligation to be able to help them with specific patients. So we only have a need-to-know access to patient data. We do not look at patient data unless we have a need-to-know to help you. I think that's all the questions, Leena. Did you have anything else that come in that you wanted to talk about?
I don't think so. I think you covered everything. And thank you all so much for joining us today. And we are so excited to be collaborating with each other. And we will definitely be sending out a follow-up email to everyone who registered for the webinar with the slides. We will be posting the webinar recording on both the CHADIS website and the NPPC member website. And in our email, we'll also include information about how to join the research project that Barbara talked about, as well as how to join the NPPC. So thank you all again for your time, and hope you have a great day.